Hello, everyone. Welcome back. We're about to get started. I hope you enjoyed the time networking with your colleagues and visiting the generous vendors that have made this possible. I'm Raquel Gonzalez. I'm one of your co-moderators. I'm an assistant professor at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. This is Dr. Matt Santoria here, associate professor at Children's Hospital of Atlanta, and we'll be co-moderating this session. It's our second scientific session. If you are evaluating, don't forget to use the QR code behind your badge to do so. And I'm going to let my co-moderator, Dr. Santori, present our first speaker.
Very good. Our first presenter is Niziko Nchinda, and she is presenting association between same-day discharge and readmission rates for common pediatric surgical cases in NSQIP Pediatric Analysis 2012 to 2022.
We'll get there. Get your slides.
All right, thank you. I have no disclosures. Same-day discharge is becoming more common for the management of elective pediatric conditions. And in literature, we've seen that same-day discharge rates can be used as a marker of perioperative efficiency and also quality of care. Few studies have evaluated same-day discharge, though, in the elective management of conditions other than acute appendicitis. Prior work has shown that same-day discharge is not associated with an increase in 30-day hospital readmission rates. In this study, same-day discharge was assessed following appendectomies in pediatric patients over a 3-year period. However, there are a lack of studies that assess same-day discharge in other elective procedures and over a longer period of time. Thus, we aim to assess the safety profile of same-day discharge for multiple elective pediatric surgeries. We obtained our data from the validated American College of Surgeons NSQIP pediatric database, and we selected 7 common pediatric surgeries. So these were procedures where same-day discharge was more likely to be implemented. These included laparoscopic appendectomy, cholecystectomy, pyloromyotomy, Nuss procedure, hemithyroidectomy, laparoscopic gastrostomy tube placement, and also gastrocutaneous fistula closure. We excluded patients who were 18 years and older, had a hospital length of stay beyond 2 days, and also cases of perforated appendicitis. We focused on 3 time points over a decade period, and our primary outcomes were 1, same-day discharge rates, and also 30-day hospital readmission rates, comparing a subgroup that had same-day discharge to a subgroup that had a hospital length of stay of 1 to 2 days. We performed univariate and multivariate analysis and compared odds ratios. From our initial database query, about 20% of the patients had a hospital length of stay beyond 2 days and thus were excluded. And this resulted in a total of about 40,000 patients that were included in this study. About a third of them had same-day discharge, and about 2/3 of them had a hospital length of stay of 1 to 2 days. Overall, collectively, we saw that the amount of same-day discharge cases increased over the study period. We did not see any demographic factors that were significantly associated with same-day discharge rates consistently through the 3 time points. We did see that there were 5 procedures for which same-day discharge rates continued to increase throughout the study period. These included laparoscopic gastrostomy tube placement, gastrocutaneous fistula closure, laparoscopic appendectomy, laparoscopic cholecystectomy, and also hemithyroidectomy. When we compared the subgroup that had same-day discharge to the subgroup that had a hospital length of stay of 1 to 2 days, we saw that same-day discharge was not associated with an increase in 30-day readmission rates. There are limitations to this study. It's retrospective, and so we can't make any causal conclusions. Not every institution is included in the NSQIP pediatric database. And also with this approach, it lacks patient-level and hospital-level details. So there might be particular perioperative protocols at a specific institution that could play a factor. However, in seeing that same-day discharge is safe, the next question is, how do we utilize it? What is the impact on our delivery of care? And it is important to consider that same-day discharge does have the potential benefit of decreasing healthcare expenditures and that patients are spending less time in the hospital. However, it may not be appropriate for every patient, and so in assessing quality, there's a need to balance efficiency with patient and family satisfaction as well. Overall, we saw that same-day discharge rates have continued to increase, and that same-day discharge is not associated with an increase in readmission rates. However, as we assess it as a potential marker of quality and safety, we also need to consider if there are any predictive factors in when same-day discharge is implemented, and have further studies to better understand when it is appropriate to offer same-day discharge. Thank you for your time. I am happy to take any questions.
The floor is open for questions.
Mohammed Emran, Corpus Christi, Texas. Thank you very much for a nice presentation. It's good to see that these things are being addressed, because we've been discharging those gastrocutaneous fistulas for the past 20 years immediately post-op. But the question I had was, why was pylori myotomy included as one of these cases, since the primary reason for watching them is for the apneas that happen in the first 12 hours?
Yeah, that's a good question. We included pyloromyotomies given our own institutional data, and seeing that there is a small subset, about 5% of patients, where they can be discharged the same day safely. And again, kind of what you're saying of risk of apnea. So it's really considering the patient factors, things also like how they present. Are they coming in with a lot of electrolyte abnormalities where they need a lot of resuscitation? Where there's an increased risk, those would not be appropriate cases. But there are a small subset that come in where it's a rather acute presentation, and if they're coming in very early in the morning, say 7 a.m., it may still be reasonable that they're watched 6-7 hours post-op and could still go home the same day.
Very good. Looks like we'll move on to the next presentation. Thank you very much. The next presentation will be done by Monica Milovichev. It's implementation of a clinical pathway for shortened antibiotic therapy in children with complicated appendicitis.
Thank you for this opportunity. I have no disclosures. In July of 2023, we received a semi-annual report from the American College of Surgeons National Surgical Quality Improvement Program Pediatrics targeted on complicated appendicitis. This showed the rate of prescribing antibiotics upon discharge for this patient population at our institution was 95.7%, higher than most of the peer hospitals in the NSQIP-P program, where the median was 69.2%. We know that findings from the STOP-IT trial in the adult population and new research from pediatrics has shown that abbreviated antibiotic courses can be safely utilized without increasing rates of postoperative intra-abdominal infections or complications. Our previous clinical practice guideline for complicated appendicitis was written in 2013 with the guideline of that regardless of how long they received antibiotics in the hospital, they were discharged home within an additional 7 days. This previous clinical practice guideline could have potentially been adding to increased antibiotic resistance and higher healthcare costs without adding extra benefit to the outcomes. So our aim was to decrease the amount of antibiotics we were prescribing at discharge from 95.7% to less than 35% by January of 2025. In July of 2023 is when we identified this problem. In December, we developed our QI team and created a comprehensive clinical practice guideline. We completed order set revisions, education with providers, created a note template for postoperative documentation, and uploaded our clinical practice guideline to a repository that was easily accessible for everyone from January to March. And April was our go live date. And then we completed data collection in an interrupted time series from January to December of 24. And then we've also completed from January to March for continued maintenance. So this is our new clinical practice guideline, and highlighted here is the section that directs discharging home without antibiotics if patients have received greater than or equal to 3 days of antibiotics postoperatively. Our primary measure was the proportion of patients receiving oral antibiotics at discharge. Secondary was total IV plus PO, antibiotic duration, and our balancing measures were length of stay, organ space infection rate, and ED visits or readmissions within 30 days. Our primary outcome measure was the percentage of patients discharged home with oral antibiotics. And with our historical data, you can see we were prescribing nearly 100%. April was our go live date for our new clinical practice guideline. And as you can see, the data was quite variable during this transition period as providers were adopting this new practice. And then around mid-August, it drops down, and now we are nearly always prescribing below our aim of 35%. Our secondary outcome evaluated was the total antibiotic duration, and you can see our median went from 10.1 to 6.1 days. So despite the decrease in antibiotic utilization, the hospital length of stay has remained around 4.7 days. However, there is more variation noted, and one special cause variation in the maintenance period. We did look into that, and we had 2 patients in that subgroup that stayed greater than 15 days. So we will continue to monitor this closely. Upon review of our percent of ED visits within 30 days, there was 1 special cause variation during the maintenance period. However, after review, there was no common cause, and there continues to be no increase or trends upward since that time. Of those 5 that were ED visits, these were the different diagnoses that they came to the ED with, and 3 of those 5 were admitted. Our percent of readmission showed no special cause variation. And the balancing measure of organ space infection rate requiring IR drainage showed 1 special cause variation, as it was on the upper control limit during the post-implementation group. However, after review, there was no need for any change in practice, and there's no continued trend upward. So in conclusion, the implementation of an evidence-based clinical practice guideline in our institution resulted in a substantial reduction in the duration of antibiotic therapy for pediatric patients undergoing appendectomy for complicated appendicitis without compromising safety. This approach has led to the potential to reduce antibiotic-related complications and healthcare costs, as well as promote antibiotic stewardship. So our work supports the continued evaluation and adoption of antibiotic reduction strategies for complicated appendicitis across pediatric institutions nationally. This is a QR code that takes you to a copy of our clinical practice guideline, or you can email me with any questions.
Anybody have any questions from? So one of the questions I had is, you, like all quality projects, you showed great improvement with your control chart and really nice data there. You're in maintenance period right now, so March 2025. How do you think you're going to maintain that, and what process has you put in place to make sure that you keep that those results?
So I will say one of the most difficult things was I had to do a lot of manual data review for this, but we are in the process of creating a Tableau dashboard so we can have real-time results that we can continue to monitor.
Hi, Scott Short from University of Utah. Congratulations on achieving this. I know getting consensus around these is particularly challenging, and it's not surprising for me to see a little variability in the transition period. My primary question is it looks like you've chosen a minimum of 3 days as a requirement. Can you, we also have a progressive protocol where we just stop them at time of discharge and don't tie it to the 3 days. Can you comment as to why that time frame may have been chosen and the potential benefits?
Sure. So we did initially start with the 4 ± 1, like in the Stop It trial, but that seemed to cause a lot of confusion. So then we just chose 3 days. They do receive antibiotics throughout the duration of their hospitalization. They just are not discharged with them if they've gotten at least the 3 days. We will occasionally have some patients that are only there for the 2 days. So if they're only in the hospital 2 days post-op, then we will give them an additional day of antibiotics.
I think we have time for one quick question. Go ahead.
Hi, Ibukunlua Raoye from Alberta Children's Hospital in Canada here. But just curious what antibiotic choice you're usually given for that 3 days, if it's standardized or it kind of varies between the providers.
We use Zosyn. Unless they have an allergy, then we use ciprofloxacin.
All right. Great work. Our next abstract is Imaging Stewardship for the Diagnosis of Pediatric Appendicitis, One Institution's Pathway to Improve Diagnostic Accuracy of Ultrasound by Dr. Turpin from Nemours Children's Health.
Thank you for the opportunity to present today. I have no disclosures. So treatment for ileocolic intussusception begins with an attempt at reduction with enema. However, if the enema is not successful for reduction, the child will then require operative intervention for reduction and possible bowel resection. Recently, there has been data to suggest a benefit to doing a second repeat enema after a first failed attempt. The potential benefits include decreased need for operative intervention and possible bowel resection, decreased length of stay, and decreased costs associated with said hospital stay. In the available literature, there has been no evidence of an increased risk of complications associated with doing a repeat enema. However, the literature is quite variable in terms of when is the best timing to do such a repeat enema. We began conversations about doing a repeat enema at our institution many years ago. However, the main stumbling block is when is the ideal timing, as there is pushback by the radiology department to do these in the middle of the night. However, now that there is sufficient data to show that it is safe to wait 14 hours or longer for a repeat enema, that was the stepping stone we needed to introduce the second attempt. Another area for improvement of reduction of intussusception with enema is the use of wall air. At our institution, while simultaneously developing a protocol which included a second attempt enema, we also introduced wall air. The benefit of this is that it allows radiologists to provide a constant steady pressure rather than the variable from the manual pressure. Pressure does not exceed 120 millimeters of mercury, and it has been demonstrated to have a higher success rate of reduction and no increased risk of perforation. Therefore, we set our goal to improve the success rate of air enema reduction for intussusception from 83 to 91% within 12 months of the implementation of our protocol. To accomplish the same, we created a pathway which includes the use of both the delayed repeat enema and wall air. Patients who fail first attempt will undergo a second attempt 4 to 14 hours after the initial attempt. They will also undergo a repeat ultrasound 1 hour prior to the second attempt to ensure that there was not spontaneous reduction of the enema of the intussusception in the interim. All patients presenting with ileocolic intussusception are eligible for participation. However, patients with a concern for peritonitis and those who had no movement during the first enema are not eligible. To help facilitate compliance with this pathway, we also created a second attempt protocol order set in our EMR. Our first process measure was the percent of wall air usage. As you can see, our baseline median was 45% before we introduced this protocol at our institution. We had a steady increase since introduction, and then in the fourth quarter of 2024, we saw a decrease to 25%. We did provide a targeted feedback with our radiology department and saw a subsequent increase in the following quarter. Next is our percent compliance with a second attempt enema for patients who failed the first attempt. Again, the mean average of patients undergoing a second attempt was quite low at 28% before introducing the second attempt. However, since introduction, we've had 100% compliance with the protocol. And lastly is our outcome measure of inches, which is the percent of successful reduction. It is important to note that our baseline mean for successful reduction was already quite high at 83%. However, we have improved our rate of reduction to 90% since we introduced wall air and the second attempt. It looks like there was a slight dip in the last 4 quarters, which is true, but if you note that we've had a very small N for the last 4 quarters, and since introduction, we've technically only had 3 failures. So in conclusion, wall air usage and delayed repeat enema can decrease the need for operative intervention and is not associated with an increased risk of complications. Obviously, our major limitation is the small number of patients that we've had who've presented with intussusception. And to help combat that small N, we're working with our partner hospitals within our enterprise to help increase that number. I'm happy to take any questions. Thank you.
The abstract is open for questions. Well, I have a question, clarifying. Dr. Turpin's presenting 2 abstracts, so she actually presented right now, improving success rate of enema reduction for intussusception. How did you get radiology buy-in? Can you describe that process for us?
It was a lot of effort from a lot of discussions and presentation of the existing literature to demonstrate that it was a safe and effective mode. But we have very progressive radiologists now that are willing to try these things for us, which is great.
Awesome. Did you feel like you had a champion within radiology that?
Yeah, definitely.
Perfect.
Yes.
Next question.
Previous studies had suggested that a longer time between the time of onset of symptoms and reduction resulted in actually better outcomes as far as not having recurrence. Did y'all notice anything about the recurrence rate of the intussusception after your delayed reduction with the second attempt?
We have not had any recurrences for patients who underwent a second attempt.
Will be our last question.
I might have missed this, but can you tell us what percentage of second attempts were successful?
We've had one successful second attempt. We've had 3 failures and one of them was successful.
What's the total N for second attempts?
So I think we've only had 3 patients who've undergone a second attempt since we've unveiled the protocol. And one of them was successful, so 33%.
And does that include members of your surgery team who, I don't know if that counts as a second attempt, but in my world, it's not uncommon for a radiologist to say, I couldn't reduce it, and then I run down and I reduce it, but I don't call that a second attempt.
That's not including that, no.
Does that happen at your institution as well?
No.
All right. Moving on, Dr. Turpin will now speak to us about imaging stewardship for the diagnosis of pediatric appendicitis and her institution's pathway to improve diagnostic accuracy of ultrasound.
Okay, thank you again for listening to me. I again have no disclosures. So there are multiple different imaging modalities which can be used for the diagnosis of appendicitis in pediatric patients. The use of CT is associated with ionizing radiation and requires the administration of IV contrast. MRI is an accurate means to diagnose appendicitis, but it is not always easily accessible, and both CT and MRI are associated with increased cost. However, the major barrier to adopting ultrasound as commonplace is user dependence. That being said, given the benefits of ultrasound compared to CT and MRI in terms of charges and ED throughput, our goal was to make ultrasound the first-line imaging modality. So how did we make ultrasound first-line? Some historical background. It's important to note that in 2017, our diagnostic rate of ultrasound for appendicitis was only 27.1%, and we were a highly MRI avid center. So to help adopt ultrasound as the first line, we formed a QI team, we created a standardized imaging report template, began sonographer training, and introduced a pediatric appendicitis score guided pathway. With our QI team, we established 2 aims. First, to monitor and improve the diagnostic rate of ultrasound for all patients with suspected appendicitis and implement a change in the imaging pathway to justify these changes and sustain or decrease the clinical team time. Sonographer training began in August of 2022. It used volunteer patients aged 3 to 18 who underwent bowel and appendiceal ultrasounds at that time. Sonographers were provided with real-time and directed feedback by radiologists and more senior sonographers, and we still to this day have ongoing quality assurance programs where difficult ultrasounds are reviewed by the radiologist and with the sonographer afterwards. This is our radiology template. The template has allowed us to track the results of imaging in real time without requiring a chart review, which has allowed us to measure how we are performing and justify a change in the pathway. And this was the original pediatric appendicitis score-based imaging pathway. I apologize for this being a bit small, but I want to draw your attention to the fact that initially, patients in the moderate PAS group with a score of 4 to 6 underwent MRI initially, compared to the high PAS probability, a score of 7 to 10, who underwent ultrasound initially. This is because of our historically worse performance in the moderate PAS group. After seeing significant improvements in our ability to visualize the appendix and our diagnostic rate of ultrasound, we altered our pathway so that patients in both the moderate and high PAS group underwent ultrasound as the first-line imaging modality. This change took effect in May of 2024. Our first outcome was the percent of diagnostic ultrasound. So as I mentioned, in 2017, our rate of diagnostic ultrasounds was as low as 27.1%. Since then, we've improved our rate for all PAS groups to 56%. This change has been sustained across all PAS groups, with the median rate of diagnostic ultrasounds being 54% in the moderate group and 60% in the high group. Next is our clinical team time. This is defined as the time in which a patient is roomed in the ED to a time disposition and decision is made. As you can see, prior to the implementation of this change, our baseline clinical team time was 347.6 minutes, and our current average is 299.3 minutes. Use of ultrasound has also had a positive impact on the average imaging charges per patient. So from November 22 to April 2024, the average imaging charge per patient was $6,200, compared to after when all patients were undergoing ultrasound initially, where the average charge is now $4,800 per patient. So in conclusion, sonographer training and a standardized template can be used to help improve the rate of diagnostic ultrasounds, which can lead to decreased ED length of stay and decreased average imaging charges. Quality improvement processes can be used to improve the diagnostic capabilities of ultrasound so it can become the first-line imaging for pediatric appendicitis. Thank you.
Questions?
Hi, I'm Anthony Crisatello. I'm a general surgery resident in Temple, Texas. Thank you for presenting. And that was a really significant change in the cost. I just wanted to ask you may not have those numbers, but you can sense whether your rate of negative appendectomy where the appendix was normal changed at all.
No,
The guideline.
we did look at that. I don't have the exact numbers off the top of my head, but it has not increased since we've been using ultrasound.
It looked like I'm around Corpus Christi again. It looked like the higher appendiceal scores were still getting imaged. What percentage of your patients were clinically diagnosed with appendicitis without getting imaging?
0%, approximately.
Hi, Doug Barnhart from Salt Lake City. Just a question of how you implemented this. I think many children's hospitals would have ultrasound be the default study for every child before any other imaging. It seems like you made a choice to still leave this up to, there must be some provider selectivity of using an MRI as the first line, and it seems like your imaging costs are high. Now that you have more confidence with it, are you going to move to have it be that every patient has to have an ultrasound before you can get an MRI? And then the practical question, do you have 24-hour ultrasound in your hospital, or is that one of the limitations that you're actually working around?
So we did adopt our protocol after we saw the changes, and now all kids with suspected appendicitis do get ultrasound as first line and only will go on to MRI if it's equivocal and there remains persistent concerns. And we are fortunate to have ultrasound capabilities 24 hours of the day.
I had one question. The patients that have the equivocal ultrasound, like the category 3, how many of those patients got a CAT scan and how many of those patients went to the operating room?
So what happens in that case is that patients are reassessed by the ED, and if there remains a persistent concern for appendicitis, then they will undergo MRI at that time. We very rarely take a kid to the OR for an appendectomy after an equivocal ultrasound.
We have to move on.
One more?
We have to move on. Next speaker is Dr. Catherine Yip. She's from Mount Sinai Hospital. She's going to be discussing the impact of an interactive online dashboard on compliance with pediatric surgical antibiotic prophylaxis guidelines.
Good afternoon, everybody, and thank you so much to APSA for the opportunity to present my research here today. This was a study of the impact of an interactive online dashboard on compliance with pediatric surgical antibiotic prophylaxis guidelines. We have no disclosures. It is known that adherence to surgical prophylaxis guidelines is highly variable among pediatric surgical specialties. Some studies have found adherence rates between 27 and 60%. In this study, we sought to assess our institution's rate of surgical antibiotic misutilization, evaluate trends over time, and implement methods to improve adherence. The importance of this study stems from the need to balance reducing surgical site infection risk with appropriate antibiotic use, while maintaining antibiotic stewardship to prevent the development of resistant organisms. Compliance rates with different aspects of surgical antibiotic prophylaxis guidelines vary widely. Types of misutilization include administration after initiation of surgery, receiving antibiotics when not indicated, not receiving antibiotics when indicated, and inappropriate antibiotic spectrum, whether that is too broad or too narrow. Noncompliance to surgical prophylaxis guidelines can lead to increased adverse effects, including surgical site infections and antibiotic resistance. In our study, we first quantified our institution's rate of antibiotic misutilization using data from pediatric SAPSAR reports that spanned from July 2021 to December 2023. This gave us information on rates of misutilization, overutilization, and underutilization. We then implemented a two-pronged approach beginning in August of 2022. This included direct provider education of appropriate prophylaxis guidelines and the launch of an interactive dashboard with specialty-specific statistics and a searchable database of prophylaxis guidelines. All right, my apologies. There is a video embedded in this, but it seems the audio to it is not working. This was a sample scroll through of working with our online interaction.
To obtain information regarding prophylaxis guidelines for a PSART, for example, you would click on general surgery, colorectal, then posterior sagittal anorectoplasty. Here, you can see that both prednisolone and metronidazole are suggested, along with weight-based dosing guidelines. This process can be repeated for multiple different procedures, and future plans are in place to continue adding to and editing this dashboard.
Okay.
This is an example of our online
Okay. So as you can see in the graphs below, this two-pronged approach was shown to be effective in improving rates of prophylaxis misutilization, overutilization, and underutilization. The graph on the left demonstrates that our overall rates of each largely decreased after implementation of this intervention. The graph on the right demonstrates improved adherence to the guideline that low-risk, clean procedures do not require antibiotics. We also observed improved metrics related to the timing of antibiotic administration prior to incision and choosing the appropriate spectrum of antibiotic. During the study period, there were no significant changes in the rates of adverse events, including surgical site infections and C. diff infection. In conclusion, we demonstrated that the combination of an interactive digital dashboard with direct provider education improves adherence to surgical prophylaxis guidelines without compromising outcomes in pediatric patients. Future directions include expanding the antibiotic dashboard's accessibility, making a mobile dashboard for convenient bedside provider use, and continuing ongoing feedback to providers on antibiotic misutilization at our institution. Thank you to everyone, including my mentor, Dr. Coakley, and I'm happy to take any questions or comments at this time.
The floor is open for questions.
This is a lovely study. Thank you so much. Eunice Huang, Vanderbilt University. So I love the fact that you have data available to the surgeon at the point of care. How do you encourage them to actually use it at that time?
So often we have some attendings who are in charge of the antibiotic stewardship program at Mount Sinai, and they will often pop into the OR and encourage us to abide by such guidelines. There's also, we conducted focus groups between each specialty, each pediatric specialty that's mentioned in the SAPSAR, to kind of improve compliance rates and discuss the appropriate prophylaxis guidelines.
And then the second question for you is, once that information is, that knowledge is delivered, they will have to transfer that to the EHR to do the order set, or do you have linkages such that it opens up an order panel and they could just click on a button to be able to actually placeholder?
Thank you for your question. That's actually, we don't have a link to the order set. The dashboard is currently separate from Epic, but that would be a great way to improve the dashboard. Thank you.
Thank you.
Pete Menechny, Nemours Children's Health. Do you have data on how many times people clicked in and used the dashboard?
We do not currently, but that would be another useful metric.
Because sometimes just talking to people about the availability, the Hawthorne effect, right? You've got this, people know we're paying attention to it, makes people better. So it would be helpful to see that.
Yes, thank you so much.
Another question I have, did you notice a differential in the specialties?
I think there were certain subspecialties that had worse compliance rates that were under the kind of national SABSTAR average. Yeah.
How about improvement, like after your education and introduction of the dashboard, did you see people adopting certain specialties?
We did, yeah.
Which ones?
So we noticed it in neurosurgery and orthopedic surgery.
Nice. Oh, great. All right.
Thanks very much. We're doing a very similar thing in my hospital. We haven't come up with a dashboard yet. It's a great idea. But did I read this correctly that in clean class 1 cases, you were able to get people from using antibiotics 70% of the time to about 50% of the time, when the aim is 0% of the time? Is that kind of where we are in your?
We got to around 40% of the time. So not a complete 0% of the time, but an improvement from our original 70.
My institution, we're at like 15%. We're working really hard to get to 0. So I was a little surprised by maybe I read that wrong. Okay.
Thank you.
Good job.
Yeah.
Our next presentation is by Dr. Andrew Mudgerek in the implementation of remote patient monitoring to reduce gastrostomy tube resource utilization.
Thank you for the opportunity to present our work. We have no disclosures. At our institution, we identified high G2-related resource utilization, including many unplanned clinic visits, frequent calls from concerned families, and 500 to 600 ED visits per year. To minimize preventable complications, reduce unnecessary ED and clinic visits, and improve the quality of life for patients and caregivers, we implemented a remote patient monitoring, or RPM, program. We set a SMART aim to reduce ED and clinic revisits related to new G-tubes by 50% within 90 days following surgery. We created a driver diagram to identify and prioritize interventions to achieve this SMART aim. Family knowledge and skill acquisition, availability of expert-level help and resources, and proactive management were identified as key drivers, from which additional secondary drivers were identified as shown. Interventions for each of these drivers were proposed, and those in red boxes were prioritized and implemented. These included the development of instructional G-tube videos, education sheets, and surveys to identify patient-family knowledge gaps and postoperative complications. Prior to implementation of our RPM program, patient families routinely had 3 perioperative touchpoints: the initial surgical consultation, the time of procedure and immediate post-op recovery, and a post-op follow-up visit 4 to 6 weeks after G-tube placement, as shown on the green line here. Pain points we identified in our pre-intervention workflow included long pre- and post-operative education sessions, which caregivers found overwhelming and made information very difficult to retain long-term. There are also a long period in between touchpoints and minimal post-operative contact outside of the post-op visit, which led to caregiver frustration and uncertainty, which resulted in additional clinic and ED visits. The RPM program shown in the blue line was a 6-month intervention implemented in September 2023, involving the pre, peri, and post-operative phases of care. Patients were identified for the program during their first G-tube consult visit, and at that time were offered to enroll in the RPM program. Through the Care Companion platform of Epic MyChart, enrolled families were periodically sent questionnaires, participated in check-ins, and were assigned educational materials. Based on the caregivers' responses to questionnaires, targeted education, supplies, resources, and additional support was provided. And as you can see, comparing the RPM program timeline to the pre-intervention timeline, there are many more touch points and opportunities for caregivers and staff to interact. To evaluate outcomes following RPM program implementation, we performed a retrospective review and included all patients who met inclusion criteria between March 2022 and February 2025. To adjust for demographic differences, we performed one-to-one propensity score matching, and we generate scores according to patients' likelihood of enrolling in the RPM program based on the listed variables. We compared outcomes between RPM program participants and non-participants, and our primary outcome measures included G-tube-specific clinic visits, ED visits, clinic phone calls, and hospital readmission or ED revisit within 90 days post-op. A total of 440 patients met inclusion criteria, and of the 207 eligible patients within the RPM program, 70.5% enrolled or completed the RPM program. One or more questionnaire or education tasks were completed in 69.2% and 55.5% of RPM program participants, respectively. The patient cohort during the 18-month period following RPM program implementation differed in racialization, ethnicity, and had lower SVI scores compared to the cohort of patients 18 months prior to the intervention. Based on propensity scores, all 146 RPM program participants in the post-intervention period were matched with 146 non-participants in the pre-intervention period. And after matching, demographic differences between groups were no longer statistically significant. Comparing healthcare utilization between groups in the propensity match cohort demonstrated no statistically significant difference in G-tube-related clinic calls or additional clinic visits. However, overall, G-tube-related ED revisits were 50% lower in the RPM group, and 90-day post-op ED visits were 52% lower, the latter of which was statistically significant. And there was no difference in G-tube-related 90-day readmission rates. There are several notable limitations in the study. For one, it's a single-center study, and consequently, generalizability may be limited. And given the observational retrospective nature of the study, confounders may influence our results. We did attempt to mitigate this with the propensity score matching, but unmeasured factors may still impact these findings. And importantly, our data does not capture hospital ED visits outside of our institutional system, which may affect the accuracy of our findings as well. In conclusion, these early results demonstrate this RPM program is an effective method to reduce unnecessary healthcare utilization by proactively identifying caregiver needs, providing prophylactic caregiver education, and ensuring timely support. We hope that sharing the details and early results of this RPM program will reduce the burden for others to create similar programs. And I'd just like to acknowledge and thank all the hard work from everyone on the QI study team, and I thank you for your attention. And I'm happy to take any questions. If you're interested in additional materials related to this work, I've included a QR code linking to our AppSec QSC toolkit.
Thank you for helping us help our G2 patients. I think it's a population that really, has a high complication rate return to system. I'm Lauren Berman from Nemours. So I was wondering, when you do a propensity match, whether we're losing some important information. You said 70% enrolled.
Mm-hmm.
And then there were some differences in demographic characteristics in the enrolled and in the unenrolled, but then you kind of controlled for those. So were there demographic differences in that 30% who didn't enroll? Because we know a lot of the time the patients who are missed are the ones who are more vulnerable to complications, lower SES, minorities, et cetera. So I'm just wondering, and maybe you flashed it up there and I just didn't see it. I think it's just important when looking at the impact of an intervention that we assess how it's impacting groups with different risk factors rather than kind of controlling for those differences.
Right, that's a very good point. We didn't look specifically at the 30% that did not enroll in the group. We did try to create similar demographics between groups with the propensity match. But that is a good point, after giving this talk, to go back and look at if there are differences between those who did and did not enroll.
We have time for one quick question.
Hi, Andrew. I'm the fellow at Cincinnati Children's. I was just wondering if you guys made any sort of attempt to try and health literacy is obviously going to be variable amongst our patient population, and whether or not there was any attempt to kind of identify some of those factors preemptively and adjust some of those education materials that we're giving to our patients accordingly.
Yeah, absolutely. Although we didn't specifically look at health literacy based on the questionnaires and the needs that patients and caregivers provided, we were able to provide additional resources for those perhaps who may have had lower health literacy. And one thing that we didn't note that our resources are in different languages, but only those who spoke English were enrolled in this sort of preliminary early version of the RPM program. In the future, we do hope to include this, for Spanish-speaking patients, for example, as well.
Perfect. Thank you.
Yeah, thank you.
Great. Our next presenter is Melissa Matthews. She's going to be discussing same-day discharge after surgical gastrostomy tube placement in children. She's coming from Vanderbilt University.
Thank you for the opportunity to present my research. And it's not moving. Yeah, it's not moving.
Sorry, can you just let me have control of that?
Yeah, yeah. Okay. You can move forward. I have no disclosures. Okay, perfect. Still not moving. Here we go. I have no disclosures. So the previous creation of our institutional G-tube CPG successfully decreased time to discharge without increasing readmissions. Decreasing hospital length of stay is obviously an important aspect from a cost and patient satisfaction perspective, and we aim to further safely decrease time to discharge for a select group of patients undergoing G-tube placement. The objective was to demonstrate that the development and utilization of a same-day discharge clinical practice guideline would safely expedite postoperative care for select patients undergoing G-tube placement. We created our CPG with a multidisciplinary team and retrospectively reviewed the pre- and post same-day discharge cohorts to evaluate time to first feeding, length of stay, emesis events, and ED visits for G-tube-related issues within the first 30 days. Preoperatively, patients were included if the G-tube was the primary planned procedure, if the patient was either already on an established home NG feeding regimen, or if the patient was receiving the G-tube for either medication administration, supplemental liquids, or for future use. Patients were excluded if any additional procedures were being done on the same day that would require additional monitoring, if there was any concern for refeeding syndrome that would require a slow advancement of feeds and lab draws, or if there were any other known requirements for a prolonged observation. Although our numbers are small, there's no significant difference between the pre- and same-day discharge groups. We did note a slightly more diverse post-same-day discharge cohort. Mild protein deficiency was more likely to discharge same day, whereas severe protein malnutrition was more likely to need an extended stay. Postoperatively, the patient was admitted simply for nutrition and case management to be able to submit orders to insurance. The PACU or the floor nurse would give a quarter volume feed as soon as the formula was delivered, or a quarter volume feed of Pedialyte was given if the tube was placed simply for supplemental liquids. And we would confirm that the family had completed G-tube teaching prior to discharge. And then the family was discharged with a regimen to increase feeds to goal at home. Our outpatient APP would arrange for either a telehealth, a phone call, or a clinic appointment within 48 to 72 hours. And then we would also see the patient in clinic with an APP within 1 month. Our pre-same-day discharge cohort from March of 2022 to January of 2023 had 85 patients, which showed a mean time to discharge of 33.9 hours, with 19 patients, which was 22%, returning to the ED for G-tube-related issues. Our same-day discharge G-tube cohort from April of 2024 to January of 2025 had 9 patients and showed a mean time to discharge of 7.3 hours, with no patients returning to the ED for G-tube-related issues. In discussion, the implementation of a CPG for same-day discharge after G-tube placement was effective at decreasing length of stay by over 26 hours. In a select patient population, same-day discharge following G-tube placement does not appear to increase frequency of emesis, likelihood of readmissions, or ED visits related to G-tube issues. I'm happy to take questions, and this QR code will link to our CPG.
I'll take some questions now. I think you briefly mentioned it, but your pre-implementation and post-implementation numbers are significantly different. How do you anticipate, or you, looks like your data went to January. I suspect you're still collecting.
We are.
have you seen any differences?
We've not seen any change. We've had a couple more patients that have joined the number of 9 since that time, and those have been very similar results as well, with no returns, no complications.
Great. Wonderful.
Shunpei Okochi from Mount Sinai Hospital. Thank you so much for the great presentation. I think one of the challenges that we face at our hospital is actually the G-tube teaching portion, as well as the equipment. And I'm curious to see how you tackle those issues.
Right. In clinic, we try to have the family watch the G-tube video, which has previously been established by our education department at the hospital. And we've tried to take a more active role in the surgery department to be a part of that education to make sure that it aligns with what we want as a department versus just nurse educators providing that information, not based on what we want as a surgery team. And so ideally, the family would receive that education preoperatively. Again, we have the CPG has a QR code in it that the family can watch it at leisure at their home. So we try to have them watch it in clinic if possible. They can also review it at home if possible. And then in the PACU, once the procedure's completed, we like to make sure that they're comfortable with it. And if not, they can still refer to that. It definitely varies by state as far as the supplies part of it. Ours requires that they be admitted, and our nutrition has to have, even if they've seen the patient 3 days prior in clinic and have given a regimen, they have to provide a new note once the procedure's done before insurance will provide the formula. And the same thing for the supplies. We can't say that this is the tube that we anticipate putting in. And have that pre-ordered so that it's already delivered to the home. We have to wait until the procedure is actually done to submit it to insurance to get those supplies. And so those are barriers that we're working through. But ideally, the patient would at least have a contact with nutrition and a contact with case management in clinic and get that, that relationship established and also begin to watch the video and understand the care.
Well presented. Thank you.
All right, we're going to move on to the next presentation. Our next presentation is going to be given by Brittany Walker, and it is calculating carbon emission reduction in pediatric patient visits at outreach clinics from a surgical patient cohort.
Thank you for allowing me to present today. Unfortunately, Brittany is graduating from medical school, so couldn't make it today. We have no disclosures. So carbon emissions pose a major, climate change is a major concern right now, and carbon emissions play a major role in that. The healthcare industry currently contributes 8% of carbon emissions in the United States, and of that 8%, 20% of it is related to travel to appointments. Now, 1 in 4 children in the United States currently lives 40 miles away from a pediatric surgeon, and that increases the burden of making it to appointments, especially from children from more disadvantaged areas, where cost of travel, time off work can contribute to missing appointments. Outreach clinics can pose a potential solution to these problems. So the aim of our study was to evaluate the carbon footprint reduction achieved by outreach clinics as an alternative to patients traveling long distances to a tertiary care center. To do this, we first started with a cohort of pectus excavatum patients seen at outreach clinics in Wisconsin. We analyzed all patients from 2012 to 2024 seen at these outreach clinics. Using the EMR, we're able to use address data to calculate estimated travel to the tertiary care center and actual travel to the outreach clinic. We then used this sample of data and extrapolated it to all patients seen by subspecialists in our clinics. We used all of our calculations based on US EPA data seen below. And just for reference, this is a map of Wisconsin. Our children's hospital is located down in Madison. The first clinic is 100 miles away. The second is 146 miles away. So in our pectus excavatum cohort seen at the outreach clinics, there are 33 total patients. The average travel for our patients in one clinic was 27 miles versus an estimated 137 if they were to travel to our hospital down in Madison. Similarly, in the other clinic, it was 8 miles compared to 86 miles if they were to travel to our clinic. This is a Haversine distance of the actual versus estimated travel, and physician travel was estimated at 100 miles for one clinic and 136 for the other. When looking at all pediatric outreach visits from 2022 to 2024, there were 10,000 total visits. pediatric subspecialists at these clinics saw an average of 7 to 8 patients per day. And when looking at this table, the estimated travel distance would have been 2.5 million miles over that time period. The outreach travel distance was less than 500,000. Adding physician travel was almost 400,000 miles, leading to a reduction in 1.7 million miles, or 67.5% reduction in miles traveled. When looking at this slightly differently, looking at carbon emissions, there was 1,000 metric tons of carbon emissions estimated if they were to travel to the Children's Hospital, compared to 181 for patient travel to the outreach clinics. Adding in the 150 metric tons for physician travel to the clinics, you again have that 67% reduction, which is the equivalent energy expenditure of 145 homes over the course of a year. And this graph just shows the similar trends graphically, estimated versus outreach clinic travel. And looking at this again in terms of cost savings, not only does it save time of travel, days off work, days off school to make our appointments, but each clinic visit using the same estimations was around $26 per patient per visit. So in conclusion, healthcare leads to a substantial carbon footprint, and traveling to clinic visits is a major contributor to that. Outreach clinics do have the potential to reduce those carbon footprint compared to traveling to our tertiary centers, and they also improve access to care, enhance patient experience by reducing travel time and the burden to getting to these centers. Thank you for your attention. I'll take any questions.
Open the floor for questions. While we're waiting for someone to come up, I noticed the western part of your state, who services or provides care on that? And another question is, have you looked at patient satisfaction scores in regards to this?
Satisfaction scores are a next element that we plan to look at. As far as servicing the western part of the state, we do have another hospital system out there that usually services most of them, and some can go across the board into Mayo as well. So we have a few different, but I agree there's definitely a lot of missing geography that can be better covered.
Yeah, hi, Doug Barnhart from Salt Lake City. I think it's an interesting way to calculate the reduction of burden that you've given to patients. We cover a large geographic footprint in the West, and my question is pretty simple. Why is your doc burning gasoline? We do all these visits via telehealth. We think you can actually make an accurate assessment. The majority of this visit, particularly in Pectus, is about patient counseling, which can be accomplished by telehealth. So I don't want to make your people not drive, but that's hours in a car that a doc spent that I would argue probably is unneeded, at least in that disease. And I think what we learned out of the pandemic is most patients that come to pediatric surgery have been seen by another physician, and there's probably not much in your physical exam that actually is the expertise that we're bringing to the patient. It's our knowledge and counsel. So just interested in satellite clinic versus telehealth.
I think it's a great question. I think telehealth is also probably just as good. The data says that physical exam also isn't as important as we think it is. I think it's just a hard time to separate seeing the patient versus just virtually seeing them, meeting them the day of surgery versus physically meeting somebody. But again, I think telehealth is great.
Thanks very much. We'll move on to the next presentation.
Our next presentation is Crotolid Envenomation Score Improves Management of Pediatric Snake Bite Patients by Dr. Krishi Tielo.
That's okay. Good afternoon. I'm Dr. Crisatello, or Anthony Crisatello. I'm a general surgery resident at Baylor Scott & White McLean Children's Medical Center in Temple, Texas. Here we go. We have no disclosures. Thank you for inviting me to Montreal. I'm excited to tell you guys about this topic. Snakes pose a risk to children all over North America, though the highest incidence of snake bite is in Texas. Crotolids are a family of venomous snakes that include rattlesnakes, copperheads, cottonmouths, and water moccasins. The primary treatment is non-operative and includes the use of antivenom. Our institution uses CroFab. Prior to our study, there was no pediatric guideline for snakebite envenomation. We sought to remedy this with the creation of our Crotolid Envenomation Score. So, we reviewed outcomes from 76 patients at our own Level 2 Pediatric Trauma Center. Then with a multidisciplinary team, we created the Crotalid envenomation score. We then validated the score in 35 envenomated patients from 2019 to 2022. Many adult scoring systems are complex with 9 or 10 categories. We sought to create a simple scoring system with just 3 categories. First category is CES 0, which is mild or no envenomation. CES 1, or moderate envenomation with signs on physical exam or coagulopathy, or then CES 2, or severe envenomation with signs on physical exam and coagulopathy, or report of a rattlesnake bite. And then these are our criteria for a positive physical exam and coagulopathy. This is the associated treatment algorithm. I won't go through it in detail, but it's important to note that our CES 0 patients are observed in the emergency department without the use of antivenom. Our CES 1 patients, or moderately envenomated patients, are admitted to the floor, receive a 4-vial loading dose of antivenom, and are checked on every 2 hours. And then our CES 2, or severely envenomated patients, or rattlesnake bite patients, are admitted to the ICU with an 8-vial loading dose of antivenom and checks every hour. So the median age of our patients was 11 years old, 62% were male, and copperhead was the most commonly reported snake type, followed by rattlesnake. The only significant difference in our cohorts was a higher incidence of CES2 or severe envenomation in our post-guideline cohort. With use of the guideline, we saw a 52% reduction in our CES0 or non-envenomated patients, a significant reduction in hospital length of stay for our CES0 patients, though this was not significant. We also saw a significant reduction in ICU admission for our CES0 and CES1 or moderately envenomated patients, and there was an overall 66% decrease in hospital length of stay for our post-guideline patients. Our ICU usually runs at 80% capacity, and so it's very important for us to be judicious about our critical care use. With guideline use, we also saw a significant decrease in antivenom given to our CES0 or non-envenomated patients, and a significant increase in antivenom given to our severely envenomated patients. This demonstrates a more targeted use of antivenom. Importantly, use of the Crotalid envenomation score maintains safety. So there was no significant difference in readmission rate. 2 patients were readmitted in the pre-guideline, and 3 patients readmitted in the post-guideline cohort. 1 patient in the post-guideline cohort was transferred to the ICU after initial admission to the floor. This demonstrates repeat evaluations as an important feature of our guideline. And then 1 patient had an allergic reaction. This was treated with antihistamines, and he had an otherwise uneventful hospital course. So in conclusion, use of Crotalid envenomation score is safe. It decreases antivenom use for non-envenomated patients, and it decreases critical care use for mild and moderately envenomated patients. I wanted to note that a multidisciplinary approach to the creation and implementation of this guideline was key to its success. Thank you.
The abstract is open for discussion. I have a question. So can this be used with adults as well? Have you guys tested that or shared it with your adult colleagues?
We haven't. So prior to this guideline, and at most centers, the adult guideline is applied to kids. And so, our adult hospital has its own guideline that they follow that's been validated. So no, we haven't. Yeah.
Might be an opportunity.
This is true.
In terms of the pathway, when you see, for example, in CES0, you have to reassess before you discharge. The reassessment, are we doing pictures? Let's say that I take over for you. How do I know that there has or has not been a change? Am I using my own physical exam, a picture that was on the chart?
Thank you. That's a great question. We, especially the nursing and resident team, are very good about taking pictures of these patients. For our retrospective review, much of our evaluation and our retrospective scoring of our pre-guideline patients was done with pictures that were taken. And so we've continued that. And so a lot of it is done with pictures. And yes, all patients are reevaluated, both labs and physical exam, rechecked before discharge from the ED. So.
Nice work. Thank you so much.
Thank you.
Our last presentation is from Paulo Castro of open versus minimally invasive surgery for pediatric colorectal cysts in a propensity score matched cohort.
Hi everyone, I'm Paulo. I'm a fourth year medical student. It's an honor to be here. I have no disclosures. So colorectal cysts are rare anomalies that require surgery. They can be repaired with an open or minimally invasive approach. You'd perform a cyst excision with a Roux-en-Y or a hepaticoduodenostomy. What we want to know is, does the MIS approach lead to better 30-day outcomes in a propensity score matched cohort with similar anastomoses performed? No other study has used this method to assess outcomes previously, and there's still a lot of debate over which anastomosis to perform. So we did a retrospective study using NSQIP Pediatric. This is a database that captures patient characteristics and 30-day outcomes from more than 140 children's hospitals in the U.S. There were 3 groups, open, MIS only, and MIS converted to open. We combined both MIS groups into an intention to treat MIS group. The numbers for the groups are shown down at the bottom here. We performed propensity score matching to balance our patient characteristics. We did this twice, once for the entire cohort on the left and once for a subgroup on the right, which I'll get to in a second. As you can see in the red, about 50% of cases in the entire cohort had unknown reconstruction type, so we couldn't match for the reconstruction here. However, because we wanted to match on as many patients as we possibly could, we continued and matched on all the other patient characteristics. For that reason, we also created a subgroup where we had known the reconstruction type, and in that case, we did match for the reconstruction. Down at the bottom, you can see the numbers in each group, and they're equivalent because we did one-to-one matching. Our primary outcome was morbidity. We also further divided this into surgical and non-surgical based on the type of complications that occurred. This was all within the first 30 days after the index procedure. Just some quick definitions. So bias is the difference in proportions for any given characteristic between the MIS and open groups. Standardized bias is just the bias divided by the standard deviation. We define the acceptable standardized bias as less than 25%. Here's a graph showing the pre-op characteristics on the left, the standardized bias down at the bottom. In the center, there's a line that says balanced, meaning there's no bias for either approach. Anything that falls to the right of that favors the MIS approach, and anything to the left, the open approach. On the table to the right, you can see that there were a lot of significantly different characteristics pre-match. Looking at the graph at the top, higher weight, higher age, Asian race, these heavily favored receiving the MIS approach. And then down at the bottom, a higher ASA class, history of GI disease, black race, these all favored the open approach. And then here's what it looks like post-match. You can see that the characteristics are now hovering around that balance line, which is what you want to see post-match. We also took a look at the p-values on the right there. You can see they're non-significant with the exception of the reconstruction. And here are the outcomes post-match. So in the red, you can see that there were more surgical site infections with the MIS approach, and there were longer operative times as well. The most common complications were SSIs and transfusions, and it seems like the SSIs were driven by organ space SSIs specifically, and considering the procedure that's being performed, we consider that a surrogate for anastomotic leaks. Here's our subgroup characteristics. To the right, you can see the proportions for the reconstructions that were performed. At the top of the graph, you can see the hepaticoduodenostomy heavily favored receiving the MS approach. So we definitely wanted to account for that. And here's what it looks like post-match. So, the reconstructions were similar post-match. And then down at the bottom, you can see a red circle for oxygen support. That fell out of bounds, but there were only 2 patients on oxygen support, and the p-value was not significant post-match. Here are the outcomes for the subgroup. They were all similar with the exception of longer operative times with the MIS approach. We also looked at operative trends over the study period. So the MIS approach is being used more and more, and it was significant when we did a Cochrane-Armitage trend test. Some limitations I haven't mentioned. Procedure-specific complications weren't captured. Some of them included listed here. Anything after 30 days wasn't captured either, so it's possible the MIS approach could actually be more beneficial in the long term. That wasn't captured with our study. And clustering effects couldn't be accounted for either. In conclusion, in the full cohort, MIS approach is associated with more SSIs and longer operative times. In the subgroup, just longer operative times. Because the subgroup was so small, we felt that the analysis wasn't strong enough to fully characterize the reconstruction on short-term outcomes, and we recommend additional comparative studies. Here are my references. That's it. Thank you.
Open the floor to any questions or discussions. Were you able to, there's different types of colorectal cysts. Within your study, were you able to delineate the differences of the different types and reconstructions?
It's funny, we took that out of the limitations. It's not stated specifically which choledochal cyst was operated on, so we have no information on that. That's a limitation of this study.
And then thinking forward, how do you think long-term complications will be comparatively from open to laparoscopic?
I'm sorry, can you repeat that again?
So if we're thinking about long-term complications, you don't have any data that's past 30 days, but if you could hypothesize, what do you think the long-term complications for each of them would be? And what are the benefits for each type of procedure?
Yeah, with MIS, we always think about the cosmetic benefits, which is definitely a big one. We were also we looked at the reoperations that occurred with our two approaches, and a lot of them had to do with bowel obstruction. So, it's possible that the MIS approach in the long term might help with that more so than the open approach. Things like biliary gastritis is known to occur more often with hepaticoduodenostomy, which seems intertwined with the MIS approach for whatever reason. So, in the long term, I think the MIS approach with that might not be as great. So it's hard to say.
Hi, Pat Healy from Seattle Children's. Thank you. Enjoyed your presentation. And it's interesting just to see the experience around the country with this diagnosis. And I find it interesting the length of the operation, actually, when you consider that a hepaticoduodenostomy actually doesn't include creating a Roux-en-Y, doing a jejunostomy, and then doing a biliary anastomosis, and yet the length of time was longer. And so I don't know if there's any insight into that. The second thing is sequencing the operation, doing something about the time. I mean, your conclusion about space infection leading to surgical site infection, or being counted that way, I agree with that, but I think if it takes so much longer to do the anastomosis and resect the cyst, there's probably a lot more bile spillage that's in the upper abdomen and maybe doesn't get adequately cleared out. I mean, and just trying to understand the morbidity of a longer operation just to do one half of the other operation.
Right. Yeah.
With no difference in outcomes, really.
Yeah, I mean, I agree. I'm just a medical student. I've only seen this case once.
No, I know.
No, but I'll try to answer as best I can. So yeah, the Roux-en-Y, that's a good point. It is longer. So, why is it so much longer with the MIS approach? It must just be that much harder to perform the anastomosis, I'm guessing, with the laparoscopic tools. I don't know. I've only seen this case once, and it seemed pretty difficult. You're not being able to see not being able to see the back end of the anastomosis. I guess that seemed like the hardest for me as an observer.
Did the study ask a difference between robotic or laparoscopic approach? Because that may also that may also turn out to be a significant difference in the time that it takes.
Yeah, for sure. The database that we had, the patients that we had, it didn't delineate between robotic and laparoscopic. It just said laparoscopic MIS only, or converted. So we didn't look into that.
All right, very good. Paulo, thank you very much. We want to thank, a big thank you to all the presenters for doing a great job and a really good session. Please stop by and thank the vendors for the support of the conference and check out their offerings. You guys have some free time right now, but we invite you to attend the welcome reception at 7 o'clock. All right, take care, guys.
Thank you.